if that's okay with everybody.
It says your meeting is now live streaming.
Okay, great. Thank you. Thank you, Rob. Rob is here helping us out. Okay. Well, great. I think we are all set to go then. Well, thank you for being here today, everybody. I know it's a bit hectic. I want to go ahead and call the meeting to order and get started here so I don't take up too much of your time. So welcome to the April OFR team meeting. We're going to go over the quick agenda today. So we're going to have our call to order, introductions, approval of minutes from last month, and then we're going to set the agenda, and then we'll go through the usual presentation of our data, our brainstorming and discussion section, and then our action items, and then we will adjourn. Let's start with some introductions. I will go first. My name is Jordan Crummett. I am a public health educator and the coordinator for the overdose fatality review team here at Knox County Health Department. And I will go ahead and call on people to go next. So Pam, if you could go.
Hi, I'm Pam Liskoyak, and I'm the new admin assistant for All for Knox. Hi, everybody. Nice to see you all.
Thank you. And Candace?
Hello, everyone. My name is Candace Allen, and I'm one of the senior directors at the McNabb Center in really intensive adult outpatient programming and criminal justice programming.
Thank you. Chris?
Chris Thomas. I'm the Chief Administrative Officer here at the Knox County Regional Forensic Center.
And Darinka?
I'm Darinka Wolsting-Polchen, Chief Medical Examiner, Regional Forensic Center, Knox County.
Thank you. Greg?
Hi, folks. I'm Greg Roberts, Drug Intelligence Officer for Tennessee within the Appalachia HIDA. I partner with Michelle Trofeter in the overdose response strategy.
Thank you. And Jennifer?
Hi, I'm Jennifer Torville, Director of Substance Misuse Initiatives for the University of Tennessee System.
Great. And Karen?
Good afternoon. I'm Karen Pershing, Executive Director of Metro Drug Coalition.
And Lauren?
Hi, I'm Lauren Allard. I'm the evaluator tied to the federal funding supporting the OFR.
Michelle?
Oh, hey, everybody. I'm Michelle Trofeter. I'm the public health analyst for Tennessee. I work for the CDC Foundation, and I partner in the ORS strategy with Greg Roberts.
Awesome. And Phil?
Sergeant Phil Major, Knoxville Police Department. I'm with the Drug-Related Death Task Force.
Thank you. And Sam?
Good afternoon, Sam Lee, Chief Deputy, Knox County District Attorney's Office.
Great. Thank you. I think that's everybody. Well, thank you so much for being here today. I want to go ahead and go through the next item on our agenda, which is the approval of minutes from last month. So I did send out the minutes to you all. Does anyone have any amendments or additions to those minutes? No? Okay, great. Can I have a motion to approve the minutes?
This is Karen. I'll make a motion to approve.
And a second, please.
A second.
Michelle, yeah.
Great. Okay, so the minutes are approved. And then moving on, we're going to set the agenda. So today left on our agenda, we have the presentation of our data, our brainstorming and discussion sections, and our action items, and then adjournment. Are there any additions to this agenda? Okay, great. Can I have a motion to approve the agenda?
I'll make a motion.
Thank you. And can I have a second?
Second.
Great. So the agenda stands as approved. So moving forward, with our introductions already. Again, this is an open meeting format, so you all have been utilizing the mute and unmute functions. Also feel free to use the chat function as well if you have any questions or any discussion points throughout the meeting today. Again, our case selection criteria for right now, we are in the age range of 25 to 44, and as identified through some of the data that we've discussed previously, just want to make sure we keep this up to date. Again, we can revisit that in the future, but for now, this is where we are. And here's some of that data presented in graph form from the Sheriff's Office and from some of our other data sources as well. So moving forward, our set of cases this month are from December of 2020. We have 5 cases in total, and we'll be reviewing them in aggregate form. I have added a couple different data points that we'll go over during the meeting, and I'll walk you through some of the things that we've identified through our team that we want to start showing and discussing. But first, let's start with age and year. So our minimum for this month is 31, and the highest age was 44. As you can see, we have them put into our buckets over here on the right-hand side. We have 0 people in the groups of 20 to 25, 0 from 25 to 30, 1 in the group of 30 to 35, 1 in the group of 35 to 40, and then 3 in 40 to 45 age range. This is one of our new sections that I've added in. This is an employment and education section. So this is the known employment and education information that I have on these cases. As you can see here on the left, we have 3 out of 5 of these people were employed at the time. 1 was known to be unemployed and 1 had unknown employment status. And then on the right, we have our education status. We have 1 case with 9th to 12th grade completed with no diploma, 3 with high school graduate or GED credit, and 1 with a bachelor's degree. So these are kind of the points that we've been discussing during our meetings, things that we want to see, more information that we want to get a more well-rounded picture on these cases. This is also another point that we've been discussing, which is housing and housing stability in our community. For this set of cases, we have 4 out of 5 cases were known to not be experiencing homelessness, and 1 was known to be experiencing homelessness, and that is identified as either couch surfing or residing in a motel or hotel. And I've put over here some other factors to think about when we're kind of expanding on this information and when we're looking at housing information is possible interaction with local shelters, possible interaction with the health department, either at the county or state level, and other services for those experiencing homelessness and interaction, and a possible interaction with law enforcement, as we know that that is increased with groups that are experiencing homelessness. So that's definitely something to keep in mind when we're looking at this data as well. Moving forward, we have location of overdose incident. We have more of a split than usual, but in this case, we have 2 out of 5 were at the decedent's residence, 2 out of 5 were at a friend or acquaintance's residence, and 1 was categorized in the other category. And so the other category is anything that's not the decedent's residence, a hotel or motel, a friend or acquaintance's residence, or a motor vehicle. We also have evidence of administration, so how were or was the drugs administered. For a majority of these, we have no information on the route of administration. That's 3 out of 5 of these cases, and the other 2 were found to have evidence of injection. Substances found at the scene. What types of substances were known to be found at the scene? For 4 out of 5 of these cases, there was no substances known to be found at the scene, and in 1, it categorized into the other category. So that would mean it's not any of these items listed on the left-hand side. And a further breakdown of that, we have it broken down into the number of different types of substances found at the scene. So again, we have 4 where none were found, 1 where there was 1 type of substance found, and none of them were more than 1 were found. Moving into toxicology results, we have a full total of the overview of the toxicology results here, just to get kind of a broad overview of what we're looking at within these cases. So as you can see, we have a high of 4 out of 5 of these cases had fentanyl found in the toxicology report, as well as 4 ANPP, which we talked about at the last meeting, which is also indicative of fentanyl use. We had 3 cases with opioids as well. And then all 5 of them had things found in the toxicology results that fell into the other category as well. And then as we did at the last meeting, I have a further breakdown of this by case. This is just to give you all a better idea of exactly what kind of combinations we're seeing within each case. Again, no identifying information, but just general toxicology results. So in case 10, we're looking at 4-ANPP, fentanyl, opioids, and falling into the other category, we have something that I haven't seen before is xylazine. Michelle sent me an information sheet about xylazine. It is an uncommon drug that we're seeing. And so I will send out that information sheet to you all along with the minutes if you all want to read up about what it is and how it's commonly used. In case 11, we have 4-ANPP, cannabinoids, fentanyl, and fentanyl analogs, as well as falling into the other category. For case 12, we have 4-ANPP, amphetamine, benzodiazepines, fentanyl, gabapentin, methadone, methamphetamine, opioids, and then also falling into the other category. Case 13, we have antidepressants, antihistamines, benzodiazepines, opioids, and also falling into the other category. We have kind of a longer list on this one. And I will mention that one of the drugs listed in the other category is indicative of kratom use. I know that's something that we've been discussing in our group, so I wanted to point that out. And in case 14, we have 4-ANPP, amphetamine, fentanyl, and methamphetamine, and then others falling into the other category. Moving on into bystanders, all of these cases had at least one bystander present at the time of the incident. We have 3 cases where one bystander was present, and 2 cases where multiple bystanders were present. And a breakdown of the type of bystanders present, we have 2 of these cases where it was a friend and 3 where it's identified as other family. Now into naloxone. There was one case where it was known that naloxone was administered. It was administered by EMS, and there were 2 doses administered. So that's some of that further information that we're gaining access to, especially on naloxone administration. I know we talked about that at the last meeting as well. So that's information we're hoping to get more on in the future. We're working on getting some of the data sharing agreements ironed out on that end, but in the future, we should have further naloxone administration information on these cases as well, which is very positive. Moving into mental health history, 2 out of 5 of these cases did not have a known history of mental health problems or diagnoses, and 3 of them did. And again, that's excluding substance use disorder. And then none of the cases were known to have a history of suicidal ideation, plans, or attempts. And in the substance use disorder realm, 2 out of 5 did not have a known history of substance use disorder diagnosis, and 3 did have a known history of a substance use disorder diagnosis. And breaking that down further, substances known that the decedent had a history of using, that was only indicated in one of the cases, which is why you're seeing the 100% for all of these. But in that one case, they were known to be have a history of using heroin, methamphetamine, and other drugs as well. And again, another breakdown of this. So the one case is known to have a history of polysubstance use, and the other 4 have an unknown substance use history. So we know that they have a history of substance use disorder diagnosis, but it's unknown exactly what is involved in that. Moving on into co-occurring disorders, we have 1 case with a co-occurring substance use disorder and mental health diagnosis. And then we have 2 with a history of only a mental health diagnosis and 2 with a history of only a substance use disorder diagnosis. Criminal justice information, we do have access to some of this information now, so that's really positive, and I think that that will give us a wider range of information for our cases. As you can see here, 3 out of 5 of these cases did not have a known criminal justice history. 2 had a history of arrest, and 1 was a known incarceration. And in the 14 days prior to death, none of the cases had any interaction with law enforcement or the criminal justice system in general. So that's the full roundout of data for this month. Again, just assessing some of the current gaps we're seeing in our data. I think a lot of these were on our way to properly addressing. I think that we've had a lot of progress in access to data, and at least even just in the last month, we've had a lot of movement on that end. So I'm very happy with the way things are going. I've highlighted at the bottom here economic, educational, and employment background. While we do have some of that information available to us now, I think that there's more information that could be gathered through other means of data gathering. But again, we're just not at that point yet. But as we continue to build these relationships with other data sources, get licensing and data sharing agreements ironed out, I think that we'll get a plethora of that kind of information and be able to look more into those different categories. So again, if any of you still have not completed the data sharing agreement, or if you have questions about a data sharing agreement, or if you have information on a source of data that you think would be important for the group to know about, please feel free to talk about it today or send along an email, and we will try to address that in the future. So that brings us into our brainstorming and discussion section. Is there anything that anyone specifically wants to talk about from any of these cases or any of the data that we've presented so far, just in general, before we move into the brainstorming heavy section?
Jordan, this is Candace. I have a question. What was the rationale for the 14 days prior with criminal justice?
That is a data point set out by our funder. I think that the proximity to death is something that they're interested in looking at to see within 2 weeks of someone's fatal overdose if there was any sort of interaction. They have other questions phrased in that way. We have 14 days prior to death, was there an interaction with a mental health provider, a substance use disorder treatment facility, criminal justice system, as well as any sort of general practitioner health information as well. So I think it's trying to see, like, close to the incident, was there an interaction with a known source of possible treatment or possible intervention?
Thank you.
Mm-hmm. Anyone else? Okay, and then based on the data that you guys have seen this month, and based on the things we talked about in previous months, is there anything that you feel we've talked about before that is further emphasized by this data, or anything that you guys would like to see us focus on more in the future? I know that the added sections that I've provided today as data presentation wise has been directly from your guys' suggestions. So if there are any other things you guys would like to see in the presentation, or things you think we need to tease out a bit more, please feel free to speak up now and we can try to work that out. I know that Michelle providing that information on one of the novel drugs we're seeing is really important. That's something I'd like to do in the future as well. If there are things we're seeing in our community that are new, or any sort of novel substances, if we can provide some further educational information, at least to our team, I think that that's a good place to start, just so we kind of know what we're looking at. Does anyone have any comments on the new data portions that we've talked about today, or like any further information on that end that we think we want to discuss as far as like housing, employment, education? Are there any further or more like nitty-gritty details you would want that we could possibly access through other data sources?
So Jordan, this is Michelle. I thought it was really interesting that most of the cases you showed this month had a bystander, at least one, if not multiple bystanders present, but yet none of the bystanders administered naloxone. You know, just making a note of that.
Right.
And maybe doing something with Good Samaritan laws, like letting people know that they can intervene in the situation and provide naloxone without consequences to themselves, I guess.
Mm-hmm. Yeah, I think that's a great point. I don't know if Phil or Greg might have some further information on the Good Samaritan laws in Tennessee and how that's kind of conveyed to people, either at the scene of an incident or just in general. I don't know if that's something that's well known, or if there's a way to do some sort of educational piece on that. Any thoughts?
This is Karen Pershing, and we do community naloxone trainings for laypersons through MDC. And as part of that training, we go over the Good Samaritan law, and we make sure people understand that there won't be any liability and that they will be protected if they rescue someone.
Okay.
Yeah, and I've noticed as far as a lot of the recent reporting and a lot of the calls that our officers are going on, more and more we see where naloxone is given oftentimes by bystanders, sometimes by family members. So I think that's kind of increasing somewhat. We're starting to see it a little bit more than we used to. So I think some of that word is getting out.
I think part of the problem or issue with these individuals were when they were discovered, they were already in rigidity and cold to touch. So there was really no point in administering naloxone. It just so happened that it was too late, and it was obvious that it was already too late.
Right. Yeah, that is a factor to think about as well. I know that one of the data points that we go over in our REDCap system is if there was a delay in resuscitative efforts or calling 911, is there a reason for that or a noted reason? And what would that be? A lot of the most common ones are either someone was unaware that someone was using drugs, or they were separated in some way. So there was someone at the residence with the decedent, but they were either in another room or another part of the home or residence. And so they were unaware of what was going on until it had been a significant amount of time. So that is something that we are seeing in some of the cases as well.
Jordan, are those people, this is great, are those people classified as bystanders? How is that? Are they in the same room? Are they in the same building? How is that classified?
In our system, bystanders are classified as anyone who is at the scene of the incident when the incident occurs. So had someone been away from the residence when the overdose incident had occurred, they would not be counted as a bystander. But if they're in the same location, then they are considered a bystander by our data.
Not
so even if
necessarily
they're
in the same room.
Right. So they might not necessarily be witness to someone using drugs or someone ingesting something, but they are in the same location as them.
Just to further that point, I think a lot of these cases where the individual went to sleep and it was someone else at the residence or the property that went to check on them, and that's when they noticed.
Yeah, that is something we see.
Perhaps some of the reporting could be further delved down that when there's bystanders present, if the decedent was, or if they were known to have been found in their sleep versus an actual reaction to an overdose being witnessed.
Right.
Yes, maybe that's a suggestion for next time, because actually, three are the ones who are already in rigidity and cold. One, it looks like there was no really general awareness of the drug abuse, although it's hard to believe. And the other one, the last one, was actually a motel room with shady friends, and that could be a reason why they didn't have naloxone. So maybe just another kind of item to add to the analysis when it comes to naloxone. An explanation why it wasn't administered.
It's a good point.
Yeah, it seems like there's a definite distinction between bystander and witness.
Yes. I'm just taking some notes here.
But that could be another point too. A further investigation could find out if naloxone was actually present at the incident address, and if it had been noted, would they have had time to save them or to use it on them beforehand?
Right. Yeah, that is something that I don't see a lot in the case description or in any of the information I'm receiving, is whether or not anyone there had naloxone on their person or access to naloxone at the time. Usually
And
that's only noted in the EMS.
Yeah, we can add it to our investigation as a part of questionnaire in those cases to they can drill down if it's available at all. So
I know I've seen it noted before where it's been noted by our investigators that naloxone was present on scene, just not administered. I've seen that in other cases before.
Okay. I think that especially would be the time to ask if it was on the scene, why was it not used? Whether it be like a timing thing or if they weren't sure exactly how to administer it. I think that that's a totally separate conversation as well in that instance.
or later on, because we always have follow-up conversation with the family members and whoever is close to them, so we can get that information as a follow-up too.
That would be great.
Jordan, I was curious too, if we're getting any data on whether or not they had any emergency department visits or hospitalizations within a certain time frame before their death.
I do have information on that. I have access to Ethan as well as some other medical databases where I do get that information. Unfortunately, a lot of times there's not a recent visit to disclose. A lot of times it's a couple years prior or at some time in the past. And that's usually where I will see the information about a formal substance use disorder diagnosis is in some sort of physician noting. So that's normally where I'm getting that information. But yeah, the way that our data is set up, it's by proximity to the incident. So unfortunately, a lot of them are too far back in time to really be properly reported on. But that is something we could add in if you guys think it's beneficial to know about something that happened even 3 to 5 years ago, as far as an emergency department visit for something substance related. That's something we can discuss. Karen, what do you think?
Well, I'm just always, again, like going upstream, and are there missed opportunities that may have happened where they touch the system? And again, you know, you've got criminal justice, but you've also got the healthcare system that should be addressing this as well. And so I think having some data or being able to take data to them and say, hey, you know, these people touched your hospital before they passed away might help present an opportunity for further intervention and instead of ignoring some of the issues that they may be seeing currently.
Does anyone else have an idea on like a specific time frame we would be looking at in the past? Like, would 3 to 5 years be comfortable for you guys, or do you think that that's too far back? Maybe we should do 1 to 3 years. I don't know if there's a specific timeline you are all thinking of that would be relevant, or if you think all the information is relevant.
Well, 6 months to a year. You know, and then we also, you know, we've got the hospital navigators now too as well, that I think if we can get information, or they should be able.
Yeah. I don't know if any of them will be open to coming to the table, or if there's some sort of navigator coordinator.
Might be.
That's definitely
We can check that.
Speaking of that, have you been able to talk with Dr. Richards Van Zyl from UT and their program? That
I have not heard back yet, but I'm leaving that contact information.
The patient care pathways, because that's pretty much what they do. They try to kind of follow up with their patients.
And I'll leave my personal email and phone number. I'll contact them again today and leave my personal information if they want to get back to me, and then I can pass that along to KCHG, whoever the new contact will be, because I think it'll be a couple weeks gap until that's all formalized.
Because I know that Chris Thomas, he has been supplying them with cases. Chris, do you have any update on how that's going?
We've only done the first series. I work with one of their representatives, and they'll send me a list of their patients. We have a data sharing agreement, and I'll run them through the death certificate database and determine if any of those individuals have passed away from a drug-related death, and can notify them back. So that way it gives them a success rate or failure rate to know if these people are, once they leave the program, if they're improving their lifestyle or if they went back to drugs. So I can tell you, I mean, I don't have the exact percentage, but the list they gave me was a pretty lengthy list last time, and I found a very small percentage of them that actually ended up as overdoses, death-related overdoses. So it's a good way to, I guess, track the progress of what happens after the fact.
And obviously, they have a lot of patients who succeed at least within that certain time frame, whatever we are going to call success as. But yeah, I think it would be a better idea to kind of involve them in this conversation.
Great. Does anyone have anything else that they want to talk about today about these cases or moving forward? Other data sources. I'm still working on getting, I have movement on getting access to HMIS, which is the housing information system. That'll give us further information on people's housing situation. So that's pretty much set to go. There's just some data sharing agreements, signage and approval that needs to go through. And then that should be a data source that we're getting a lot of meaningful data from in the future as far as employment, education, housing, and other environmental factors. I think that'll really enrich some of the data that we're looking at as well.
I have a question, and I'm not sure how feasible that is going to be within this framework. Have you had in mind like contacting the family members, seeing what kind of family dynamics was there, and maybe kind of getting some information? Because I can tell you one thing that we are encountering more and more is family members' request to remove drug overdose statements from the death certificates, and which is telling me I don't know, there's still, I guess, stigma or feeling of that associated with these sorts of deaths, and sometimes even denial. I think that would be kind of interesting sort of thing to maybe incorporate. I know it's a lot of work, and might not be always rewarding, especially immediately, and each family is different, but I was just thinking maybe, in the future to incorporate part of that. What do you think?
That is something that other OFR teams are working on. I have a sample of a familial interview that Erie County uses. I think currently we probably do not have capacity for that, but that is something that I have on like a wish list of things that the OFR team could do in the future. Hopefully if we could get some more bandwidth on KCHD's end. I think that would take some movement with the approval process of getting that done because of the sensitivity of the information as well. But that is something that other OFR teams are actively working on pursuing. And there are a couple counties who are successfully doing it. So I think it's definitely something that in the future we should hope to do. Anything else?
Jordan, just a quick thought. This is Jennifer. Since some of the cases had reported injection drug use, have any of the other teams considered seeing if they had access to or had accessed syringe service program or harm reduction programs?
Yes, we do have Genoa on the team from Choice Health Network, and she does have access to some of that information. Again, some of it is a bit more private and protected, but she has been able to provide some information on previous cases. So it is something we're hoping to look at. I think that if we could get more information on it, that would be great. And then if that's something we want to pursue as well as supporting the syringe service programs that are in the county currently, syringe service program in the county currently, try to increase some of the capacity there, try to focus some of our efforts on that end. That's something we can do in the future as well, if you all think that that would be a worthwhile thing to put some effort into.
And Jordan, if I can just take a couple minutes, I wanted to mention our telehealth and OFR project that we've been working on. We're just about to the point that we can pilot that with this OFR team. So we'll be reaching out to everyone on a different platform that is not live on YouTube to let you guys know about this pilot project where we have taken a telehealth platform and rebuilt it so that it can host in a private way, HIPAA compliant OFR meetings and store the documents. So Jordan and Greg and thank you to Karen at Metro Drug Coalition because her organization has hosted this NACHO grant for us, but we'll be reaching out to you guys very soon about doing a pilot test with us.
Thank you. And yes, we're really excited about this. This is a new program that no one has really done it yet, focusing on utilizing telehealth for OFR teams. I think that's something we can all agree is very worthwhile, especially right now when everyone's meeting remotely. Being able to utilize a web-based platform that not only hosts the meetings in a HIPAA compliant, PHI compliant, private arena, but also can house the documents and all of our team communication as well in the future. So we're very excited about that project. Michelle and Karen have really done a lot of awesome work on that end. And yeah, we're moving forward with that as well. If you guys have any questions about that or any questions about what we've been working on so far, please feel free to reach out to Michelle. You can send me an email as well, but again, after today, I won't have access to it. So I will provide you all my personal email as well in the future if you do need to reach out to me, and I can connect you to the right person for sure. Does anyone have anything else to add? Okay. Well, action items. The next meeting is going to be on May 13th. I don't know what the exact format for that meeting is going to look like. It depends on how the process of filling this position goes. But I have reached out to Darinka and Brian, and they're working on a presentation about toxicology information. And that might be ready at that point. It might be time to present them. It might not be. It might be something at a future date. So be on the lookout for that about what they'll send out an update on that meeting in the next couple weeks. I'm not sure if we'll be doing a data collection for that for next month, just given the nature of the staff changes that are going on here. So again, we will be in contact about that as well. And if you guys have any questions, any comments, anything you want to add, feel free to give me a call or email me. I'm going to send out the minutes from this meeting today before I leave the office. So I will provide my contact information there if you all need to get in contact with me. And I'll also add Michelle's and Pam's contacts as well, so that you have some other contacts for information about the OFR team moving forward until we can get the new coordinator in here and getting to meet you all. Anything else?
Jordan, it's been a pleasure.
Thank you,
you.
Jordan.
Yes, thank you, Jordan.
Thank you. It's been such an honor working with you all. You guys are all amazing. Working with such experts in the field has been very enriching, and I'm really happy with the momentum that we've started, and I know that will just continue on in the future. So I'm very excited to see where this team goes.
Well, I just want to say Jordan's going to put you guys all on the hook to be on her speaker circuit as she goes to her next role, hosting technical assistance and training for the overdose response team nationally. So answer her calls when she calls you.
Yes, I have your contact information and I will use it. Great. Well, thank you all so much for being.
Good luck.
Thank you. Thank you so much. Thank you all for being here today. Again, I'll send the minutes out, and any updates you guys have, please feel free to contact me. Hope you all have a great rest of your day.
Thank you.
Thank you.